This program is brought to you by Emory University.
So I have the pleasure of introducing Dr. Kunal Bhatt, talking today about novel therapies for amyloidosis. Dr. Bhatt has been at Emory for 10 years, on staff for 2 years. He did his internal medicine training, cardiology fellowship, and advanced heart failure training here at Emory. Welcome, Kunal.
Thank you, Dr. Laskar. Thank you for being here, you guys, this morning. The focus of my talk today is going to be novel therapies in cardiac amyloidosis. I have no disclosures. My objectives today are going to be to, one, review the pathophysiology and epidemiology of cardiac amyloidosis. Two, we'll discuss the role of nuclear imaging in cardiac amyloidosis. And lastly, I'll give an overview of the novel therapies for this disease process. So before I go further, I'll just give you the punchline. It's early in the morning. If you take away this from the talk, I'll be very happy. The punchline of this talk is that TTR cardiomyopathy, when it comes to cardiac amyloidosis, TTR cardiomyopathy is very prevalent and underdiagnosed. And I hope at the end of this, you will agree with me with that. Technetium pyrophosphate is this nuclear imaging modality that is very highly sensitive and specific as a diagnostic tool for TTR cardiomyopathy, and we should be using this in our Emory system. And lastly, I hope you'll agree that there are multiple therapeutics that are on the verge of approval for this disease process. So with that, I'll start with a case. This is a patient that I saw early in my year as first-year faculty. So this was a 65-year-old male who was sent to Emory with a history of non-ischemic cardiomyopathy for further evaluation of his hypertrophic cardiomyopathy. His past medical history was that he'd been diagnosed with hypertrophic cardiomyopathy back in 2012. At the time, he had a heart cath that showed non-obstructive CAD. He had had an ICD placed the year following and had a flutter ablation a few months prior to referring to Emory. So when he came to see us, these were his echo images. So the parasternal long there you can see shows severe LVH, very severely depressed LVEF, maybe some thickening of that mitral valve as well. The short axis view there shows again severe LVH, a pretty bright myocardium. The four-chamber here then adds that not only does this patient have LVH, but also has RVH. The interatrial septum here looks a little bit more prominent. And lastly, on still imaging, his ventricular septum measured at 2.7 centimeters. Combined, all of these pictures told a story that this patient likely did not have hypertrophic cardiomyopathy. At that time, he was referred to us, where we confirmed that his diagnosis was actually TTR cardiomyopathy with a valine to isoleucine mutation. And as I will discuss in this talk, this is a very common mutation that we see in our patient population. Up to 4% of African Americans have this mutation. At the time of presentation, he was fairly advanced, and he was quickly evaluated for a heart transplant within our system. After waiting 5 months in our CCU, this gentleman received a heart transplant in September of 2017. And at the time of surgery, our surgeon, Dr. Vega, noticed that this was one of his largest hearts that he'd ever taken out of somebody. On gross path, his heart weighed 1.1 kilograms, which is about 4 to 5 times what normal size is. So what is amyloid? And this, I think, is a point of confusion for a lot of folks. So amyloid itself is just a generic term for proteins that misfold. And when they misfold, they form these fibrillar beta-pleated antiparallel sheets. And then those sheets go on to being deposited in different organs. And in this conformation, they're very resistant to proteolysis. So this in itself, amyloid itself, does not tell you much about the disease entity. It just tells you on gross path, there are deposits that have this conformation. Proteins that can cause amyloid deposition. There's over 30 different proteins. Of those, we'll discuss 2 particular types of proteins, but included in this are proteins that are thought to cause Alzheimer's disease as well as prion disease. When it comes to amyloid heart disease, I think you can break them down into three main categories. So there are abnormal proteins that exist that, because of their abnormality, the three-dimensional conformation is unstable and they misfold. And when they misfold, they cause amyloid. So these include light chains and the TTR mutated protein, which we'll talk about more. This also includes apolipoprotein A1, but this is very rare and not very clinically relevant. There are normal proteins that, when in overabundance, misfold and cause amyloid plaques. This happens in secondary amyloidosis, AA amyloid, although we don't see this disease process anymore. It's still seen in third world countries because of untreated infections and rheumatologic diseases, but we do not see it in developed countries. You can also have beta-2 microglobulin, which is found in hemodialysis patients. Again, very, very clinically rare, of little clinical significance. Lastly, for unclear reasons, normal proteins with aging misfold and cause amyloid. And of that, we'll talk about TTR, the wild type form of TTR, which is just a normal protein that, as we get older, misfolds and causes amyloid. Included in this is ANP, again, very little clinical relevance. So we're gonna focus on, in this talk, we're gonna focus on the three highlighted in red: AL, TTR mutated, and TTR wild type. To briefly give you an overview of AL versus TTR, AL is a very rare disease, and it's a disease of plasma cells. These plasma cells spit out light chains that are abnormal, that misfold and cause amyloid, and they're produced in the bone marrow. These light chains can deposit pretty much in every organ system except for the central nervous system. This, now taken in contrast with TTR, TTR is a natural occurring protein that's produced in our liver, and I'll talk more about that. But so the protein itself is made in the liver, and when there's mutations, that protein becomes unstable, can get deposited primarily in the heart or our nerves. And in the wild type form, that normal protein, as we get older, misfolds and deposits primarily in the heart. I'm going to re-emphasize this again right now, but TTR amyloid is much more common in our practices than AL amyloid, and our index of suspicion needs to be very high for this disease process. AL amyloid is traditionally what I think people think about when they think of amyloid disease, and AL amyloid, as you'll see, is a very rare disease overall. So we should be thinking more about TTR. As cardiologists, we should care more about TTR amyloid. So what is TTR? TTR is a normal protein. Again, the name comes from the fact that it transports thyroxine and retinol. It's made primarily in the liver, and it has an important role in behavior, nerve regeneration, and axonal growth. It circulates as a tetramer, as you see here in this picture depicted here. There are 4 monomers that combine to form this tetramer, and each one of these monomers in itself has a predilection for forming amyloid, or misfolding and causing these sheets. And when this protein has mutations in it, it becomes even more prone to forming amyloid deposits. So this is a nice diagram that shows the pathophysiology of TTR. So again, the protein itself exists in this tetramer form. With mutations and aging, it dissociates. These monomers then misfold and aggregate into these fibrils, and then these fibrils can get deposited in the heart or in nerve tissue, causing the disease itself. So wild-type TTR used to be known as senile amyloid, and now we've moved away from that terminology. It's called wild-type TTR. It is just the normal protein, and again, with aging, we don't know why exactly, but it deposits more so in men than women. Used to be thought as benign deposits of the elderly. However, we know now that it causes clinical disease as well. And this, by far, is the most prevalent form of cardiac amyloidosis. To show that, there have been many studies that have shown that TTR amyloid is, again, very prevalent. But I've chosen to highlight 3, the first of which was done by Dr. Redfield at the Mayo Clinic. So she looked at 109 HFpEF patients, so patients with preserved ejection fraction, who also underwent autopsies at the Mayo Clinic. So in these patients, in 109 HFpEF patients who also underwent autopsies, they found that 32% of these patients over the age of 75 had TTR amyloid in their heart. There was another interesting study that came out of Spain. So this group looked at 120 consecutive patients that were admitted to their hospital with decompensated heart failure who were over the age of 60. And so if you were over the age of 60, had HFpEF, and had some LVH, which was defined as greater than 1.2 centimeters of your interventricular septum, they then screened all of these patients with this technetium pyrophosphate scanning, which I will talk about in the next few slides. And they found that 13% of their admitted patients had TTR amyloid. Lastly, there was a Finnish cohort where they looked at 256 autopsies and found that 25%, so 1 in 4 80-year-olds had cardiac TTR deposits. So if we think about the number of patients that we see with HFpEF who are over the age of 75, 32%, that's a large number. If we think about all the patients who are admitted to the hospital who are over the age of 60 with HFpEF, who have some degree of LVH, 13% of those patients, that's a large number. And lastly, the number of 80-year-old plus patients that we see in clinic. All of this combines to tell you that this is a very large number of patients that we're seeing. Shifting gears to mutated TTR. So when there are mutations in the TTR protein, again, it becomes unstable. There are over 110 different mutations that have been identified. The most prevalent, the one that I've highlighted in this talk, is the valine to isoleucine mutation, which is thought to have originated from West Africa and is prevalent in up to 4% of our African American population. It's transmitted in an autosomal dominant fashion, and there is an estimated 10 to 20% penetrance. However, it's much higher in homozygotes. So the true prevalence of this disease is not known. The true prevalence of TTR mutated cardiomyopathy is not known. However, just looking at 4% of the African American population, that's estimated as 1.3 million carriers of this mutation. And if you think about 10 to 20% penetrance, that translates to anywhere between 100 to 150,000 patients with valine to isoleucine mutated TTR cardiomyopathy. When we look at TTR cardiomyopathy in the United States, this was a registry study called THEOS. They showed that this valine to isoleucine mutation was the most common in the United States. And up to half of the patients in the United States were diagnosed with wild-type TTR. We've done a brief retrospective study of our own patients, and we've gone through the first 75 amyloid patients that we've taken care of in our heart failure clinics, primarily seen by Dr. Cole. And our breakdown is in the first 75 charts that we looked at of amyloid patients, 54 of them had TTR cardiomyopathy. And of those 54, more than half had this valine to isoleucine mutation, which is reflective of the patient population that we see in our heart failure clinics. I mean, our patient population in our heart failure clinics is 50 to 55% African American, and we told you that 4% of African Americans have this, are carriers of this gene. The other thing to note is that in our clinic cohort, we diagnosed wild type in 37%, while the rest of the country is seeing it more in 48%. This is likely not because we don't have TTR patients who have wild type, it's probably because it's underdiagnosed. So then to talk about this rare disease, AL amyloid. So AL amyloid is a disease of plasma cells. The basics are plasma cells make antibodies. Antibodies are made up of light chains and heavy chains. And as you can see here, kappa and lambda make up parts of these light chains highlighted in the pink. The epidemiology of AL amyloid is very few patients in the United States have this disease. So 3,000 new cases a year, 10,000 total patients with AL amyloid, which earns it the designation of an orphan disease. So less than 200,000 patients become an orphan disease designation. So this AL amyloid, less than 10,000 patients, is a very rare entity when compared to TTR amyloid, which I showed you is very common, or is more common than we think. This is a nice slide that shows the pathogenesis of AL amyloid. Here's the plasma cell clone that spits out these abnormal light chains, which then go on to aggregate into these beta-pleated fibrillar forms, which then when they deposit cause anywhere between nephrotic syndrome, periorbital purpura, macroglossia, nail dystrophy, soft tissue deposits, as well as cardiomyopathy. So shifting now to workup. So the workup of this will quickly go through. The clinical features on exam of cardiac amyloidosis reflects a restrictive process with elevated filling pressures. And there's oftentimes we see prominent RV failure both by exam and by symptoms. However, there are some unique features that I think are important to mention. So carpal tunnel disease actually exists in up to 30% of TTR amyloid patients. So what happens is this abnormal protein deposits in the tenosynovium and compresses the nerve and causes carpal tunnel disease. And that carpal tunnel can present up to 10 years before the onset of cardiomyopathy. So it's a good clue that somebody may have cardiac amyloid. In a similar fashion, it causes spinal stenosis. Peripheral neuropathy of unclear etiology should also clue you into potentially other causes like amyloid. Autonomic dysfunction happens in up to 10% of TTR patients. It's much more common in the AL amyloid rare disease. And then this is a unique feature which the patient that I presented early on who got a heart transplant had. So there's also this known entity of spontaneous bicep tendon rupture, which is known as the Popeye muscle deformity, that also occurs in our TTR amyloid patients. EKG, the traditional teaching has been that EKGs present with low voltage, and these patients have a lot of conduction system disease. Here's a stereotypical EKG from an amyloid patient with low voltage in the limb leads and a pseudo-infarct pattern in V1 through V3. However, what's important to note is that in the rare disease in AL amyloid TTR, AL amyloid cardiomyopathy, low voltage is seen in 60% of patients. However, in the more common TTR amyloid, it's only seen in up to 20% of patients. So if you're always looking for low voltage as your diagnostic criteria, you're going to miss a lot of patients. Second, up to 30% of TTR amyloid patients will have LVH or will have left bundle branch block on EKG. So again, EKG itself should not deter you from this diagnosis. And lastly, pseudoinfarct is seen pretty commonly. Lab work, from an AL amyloid standpoint, these are very important. Serum free light chain assay, serum and urine immunofixation are the standard of care. They're very sensitive and specific. In fact, if you have all three of these tests negative, then that's 99% sensitive and specific. And in the past, we used to look at SPEP and UPEP, but these tests are thought to be not sensitive enough, and that up to 50% of AL amyloid patients will not have a protein band strong enough to show up on SPEP, UPEP. So serum-free light chain, serum immunofixation, urine immunofixation is the way to go. For TTR specifically, there are no lab tests, but once you've confirmed the diagnosis, then genetic testing is recommended. Echo findings, again, echo is the cornerstone of everything we do in cardiology, but the findings that are noted are usually manifestations of pretty late disease. So diffuse LV-RV thickness, into-atrial septum thickness, valvular thickness. It's the prototype restrictive cardiomyopathy, so you have really severe diastolic dysfunction. And lastly, the one unique thing on echo is this apical sparing on strain imaging that looks like this bull's eye. Cardiac MRI is great for looking for cardiac amyloid. It presents as a subendocardial or global transmural pattern of late gadolinium enhancement. The sensitivity is only 80%, but the specificity is pretty high at 92%. This test, though, cannot tell you what form of amyloid is in the heart. It tells you there is amyloid. And overall, as a screening test, it's not great, partially because the sensitivity is only 80%, but also because it's expensive, it takes a long time, patients have to breath hold. If they have devices, the images sometimes are scattered. So to fill that need for a great screening test, bone scintigraphy seems to be a great choice. So bone scintigraphy is basically nuclear imaging using bone tracers, and it's not as expensive, widely available, it's been around for a long time. It was first tested in cardiac amyloid by Dr. Falk back in the 1980s. However, after their presentation and their publication of high sensitivity specificity for cardiac amyloidosis with this imaging modality, there were conflicting results from other centers. And so the test fell out of favor. However, more recent contemporary studies actually show that there is definitely utility in this test. So it first started with this publication in 2005 by a group in Italy, where they looked at this bone tracer DPD. So technician DPD was used in patients to distinguish between TTR and AL amyloid. And they were able to show that they could distinguish the two entities with 100% accuracy. And with this publication, they also published this qualitative scoring system where if you had no uptake in the heart, that was graded as a grade 0. If you had uptake that was similar in intensity to the bones, that was graded as grade 2. And then if you had intensity more than the bone surrounding it, that was considered grade 3. Now, DPD is not approved for use in the United States. So Dr. Moore at Columbia and his group did a similar study looking at pyrophosphate testing, which is the analog bone tracer that we use in the US. And they showed, again, similarly, using both a qualitative and a quantitative method, that they could diagnose TTR amyloid with 97% sensitivity and specificity. So with these smaller studies, there was a lot of excitement to use this screening test. So there was a large effort taken by the leading amyloid centers in the world to use this test to see what its utility truly is. And so they started in 2014, and this paper was published in 2016, where the multiple centers that participated were in Italy, UK, Netherlands, France, and then there were 4 centers in the US that participated. And they had a collection of 1,200 patients or so that were referred for cardiac amyloidosis. And in these patients, they confirmed cardiac amyloidosis in 857 patients, and were conclusively able to say that 360 patients did not have cardiac amyloidosis based on other testing, including endomyocardial biopsy, other non-cardiac biopsy. But every single patient who was referred to their centers went through one form of this bone scintigraphy. So either they used DPD or HMDP, which is used in Europe, or pyrophosphate, which is used in the US. And there were a lot of interesting results that came out of that, but you can boil them down to this one sort of synopsis, which is if you had symptoms or echo findings or MRI findings that was suggestive of cardiac amyloid, and you had blood work that did not show a protein band. So if you had negative serum immunofixation, negative urine immunofixation, and negative serum free light chains, then if you used your scintigraphy results, if your score was 0, basically there was no uptake in the heart, that basically ruled out TTR, and that was 99% sensitive. If your heart had a lot of uptake of this bone tracer, then TTR was confirmed in 100% of the patients. And if your scan was somewhere in between, then those patients needed further workup with a biopsy. Now, it's important to note here that when you go through this algorithm, that in patients with TTR amyloid, and this is a phenomenon that's not quite understood, but up to 20% of TTR amyloid patients will have positive blood work for a protein band. And that's because, for unclear reasons, 20% of TTR amyloid patients have MGUS, or monoclonal gammopathy of unclear significance. And that's not clearly understood because the prevalence of MGUS in the general population is 5%. So why in this patient population it's fourfold, we're not sure. But nonetheless, if you go through this algorithm, up to 20% of patients will have a positive blood test that's concerning for a protein band, and in those patients, they need a biopsy. So I'll just mention quickly about biopsies. A non-cardiac biopsy is often not positive for TTR. That's sort of the take home. And it's really not sensitive for wild-type TTR. So if you're suspecting wild-type TTR, a non-cardiac biopsy is not going to be a great tool. No amyloid talk is complete without Congo red stain pictures. So here's a picture depicting Congo red staining, which shows up as apple green birefringence on polarized light imaging. Once our pathologist sees this particular finding, they will then send this specimen to Mayo Clinic for mass spect, which is standard of care, because mass spect is able to then do proteomic evaluation and tell you what exactly the protein is that's deposited in these plaques. So the diagnostic approach that we recommend, one, clinical concern for cardiac amyloid. If there's any clinical concern, then you should get blood work right away to rule out AL amyloid. And that's because AL amyloid is a hematologic disease that needs chemotherapy, And we know that the earlier you get chemotherapy, the better they do, which is intuitive. But nonetheless, the first step, if you suspect it, should be these blood tests. If the blood tests are abnormal, then that patient needs to be referred to hematology or to a cardiac clinic, cardiac amyloid clinic. If the blood test is completely normal, then you can get your pyrophosphate scan. And if it's positive, then you've conclusively diagnosed TTR amyloid. And the last step is to get genetic testing to see whether the patient has wild-type TTR or mutated TTR. If your test is negative, then you've conclusively ruled out cardiac amyloid with TTR. So now to go on to the therapeutic part of this talk. So once you've confirmed the diagnosis, then there's a twofold approach. One is you've got to treat the underlying heart failure that comes from this disease. And the second is you're trying to target the underlying protein production, the abnormal protein production. So to target heart failure, diuretics are the mainstay of therapy. And that's because traditional heart failure medicines like vasodilators and afterload reduction agents are not well tolerated in this restrictive process. Digoxin is thought to bind to fibrils, the amyloid fibrils, and can cause toxicity even at normal levels. So digoxin should be used with cautious use. Midodrine is used for orthostatic hypotension, which is more common in the AL amyloid patients. Organ transplantation, like I showed you in the first case that I presented, is rare but possible. And ICDs overall have not been shown to be life-prolonging. So now that you've treated the heart failure, the other targeted approach is to try to treat the underlying protein, the protein that is misfolding and causing progression of disease. So for TTR, for wild-type TTR, really, we've not had any therapies to block that protein from misfolding. And for mutated TTR, in these patients with a particular mutation who develop early onset amyloid polyneuropathy, in rare cases, those patients underwent liver transplantation. And that's because if the thought is the liver is the source of this abnormal protein. So if you put a new liver in there, then that new liver will produce the wild-type TTR, not the mutated TTR. And sure enough, they've been able to slow down the progress of disease with that therapy. The excitement in this field, though, comes from these novel therapies for TTR that target the protein itself. So up until now, we've not had any therapies, but there are multiple novel therapies that are in the pipelines. So we'll talk about the tetramer stabilizers, particularly Tafamidis, but also we'll talk about diflunisal and AG10. And then we'll talk about the mRNA silencers, particularly the two main types of technologies, the small interfering RNA technology and the antisense oligonucleotide technology. And then lastly, we'll talk about the fibril degraders, but just briefly because there's not a lot of data to guide therapy. So the theory behind stabilizers stems from the hypothesis that if you can stabilize this tetramer and limit dissociation, then you can prevent the cascade that leads to amyloid deposition. So if you can stabilize this protein, then you can prevent amyloid deposition. And this was a hypothesis that was proven true in a naturally occurring phenomenon. So a group in Portugal documented a family that all had this mutation, the V30MET mutation. And that mutation generally leads to disabling severe polyneuropathy. But that family had no symptoms of polyneuropathy. And when they evaluated that family further, they found that that family also had, on the second allele of TTR, had this T119 mutation. And what this T119 mutation did was the half of the monomers had a three-dimensional structure that made the tetramer much more stable. So despite having this Val30MET mutation, the T119 mutation basically offset the effects of the V30MET and created a very stable form of this tetramer, essentially eliminating the disease manifestation. So with this proof of concept in a naturally occurring phenomenon, Dr. Kelly out at the Scripps Institute created this structural-based drug design program that was created specifically to find TTR stabilizing proteins. And they looked at over 1,000 molecules, and of those 1,000, 3 stood out. One was diflunisal, which has been available as an NSAID since the 70s, and then Tafamidis and AG10, which are specifically designed to be TTR stabilizers. So more about Tafamidis. Again, it was a molecule specifically created to stabilize TTR. It was selected because it didn't have any NSAID properties, had good bioavailability, and it was, had low toxicity. There was good phase 1 data, which then resulted in a phase 3 study, randomized study. But the study was done primarily in this VEL-MET30 mutation patients who have disabling polyneuropathy. And so in 128 of these patients, TTR was stabilized in 98% of the patients. And with that stabilization, they found that over 18 months, the patients had reduction in neurologic deterioration, preservation of nerve function, and improved nutritional status and improved quality of life. So based on these results, the drug was approved in Europe back in 2012 by the trade name Vyndaqel, and it was also approved in Japan. However, our FDA took some issues with some of this data and requested further testing be done. So in the US, this drug has not been approved for polyneuropathy. In Europe and Japan, it's been available for the last 6 years. So to look at this drug in cardiomyopathy patients, a new study was designed called the ATTR-ACT study. So in this study, they looked at 400 patients who were given who were randomized to 3 different arms, escalating doses of Tafamidis from 20 milligrams to 80 milligrams, and then a placebo arm. And over 30 months, their primary endpoint was all-cause mortality and cardiovascular-related hospitalization. Last month, this study itself was just published. The design study was published in 2017, and last month, the results of this study were announced at the International Amyloid Symposium in Japan, where Pfizer announced that the phase 3 study had met its primary endpoint. So this drug in TTR cardiomyopathy was essentially, based on this release, was able to prevent, had reduction in primary all-cause mortality and frequency of cardiovascular-related hospitalizations. So this is very exciting, which means that hopefully this drug should be approved by the end of the year by the FDA, if this data pans out to be true, which it should. There's not much to say about diflunisal. It's an NSAID that was developed by Merck 50 years ago and was found to be a modest stabilizer of TTR, and its efficacy was proven in a polyneuropathy patient cohort. However, the data in cardiac amyloid patients comes from very small studies, 40 patients, 13 patients, which showed a delay in progression of disease. But if you can imagine giving an NSAID to a patient with cardiac amyloid is a hard sell because a lot of them have volume retention issues as well as chronic kidney disease. So it's out there, but not used much. AG10, on the other hand, again, was one of the products of this design program, which was and it was a molecule specifically designed to stabilize TTR. And it's been found to be the most potent TTR stabilizer found to date. It's more potent than Tafamidis in head-to-head comparisons in vitro. And the oral formulation was found to have no safety concerns during a recent phase 1 study, and they're currently enrolling in phase 2 studies, and we're excited because we hopefully will be part of their phase 3 study in early 2019. Now, this study was just published 2 weeks ago by Dr. Moore at Columbia and his group. So they looked at patients that they've put on stabilizers. So they looked at 120 patients, and a third of them were put on stabilizers, 2/3 were not on stabilizers, and they looked at overall survival. However, this data should be taken with a grain of salt. So with the 29 that were put on stabilizers, 12 of them were put on diflunisal. So if a cardiologist is willing to put a patient on an NSAID, that patient must be very stable, you would imagine. And majority of those patients were found to be in New York Heart Association Class 2, had an EF of 50%. When you look at the patients who were not put on stabilizers, their New York Heart Class was 3, and their EFs were 40%. So overall, patients who were put on stabilizers seem to be less sick. But when you compare the 2 arms, the patients on stabilizers look like they did dramatically better than patients who were not on stabilizers. So again, this data should be taken with a grain of salt. But nonetheless, this data plus the Pfizer announcement that Tafamidis met its primary endpoint is very exciting for this form of therapeutic. Second, I'm going to highlight the silencers because I think the underlying science behind it is really exciting. So TTR silencers are basically two technologies that have been developed to eliminate translation of this protein. So basically to prevent the protein production altogether. The first technology is this small interfering RNA molecules that bind the RNA-induced silencing complex and then bind to the appropriate mRNA, which then this complex cleaves and eliminates translation. So there's no longer any mRNA present for protein production. That's the small interfering RNA. The antisense oligonucleotides, again, do the same. They hybridize with the mRNA. They're single strand and are cleaved by RNase H. The small interfering RNA, actually, this technology is based on science that won the Nobel Prize in 2006. So Dr. Fire and Dr. Mello published a paper in 1998 that showed that this phenomenon was actually endogenous, was a naturally occurring phenomenon where our systems had a method of using interfering RNA to silence certain genes. So using this technology now, there are many different drug companies that have formulated. So this one is the Alnylam drug, and this is what put this drug on the map. This was a phase 1 study done in 2013 that looked at a potent anti-transthyretin siRNA. They encapsulated it with lipid nanoparticles, gave it to some TTR patients and healthy adults. It's administered via an IV infusion. So it's a IV-based infusion. And they showed that at 28 days, 67%, there was 67% reduction in TTR protein. So they can eliminate the protein itself completely so that it no longer deposits in the heart to cause the disease. 20% of these patients had infusion reactions. Antisense oligonucleotides, on the other hand, have been around as well for the last several years. There was a phase 1 study looking at a antisense oligonucleotide towards TTR, and they looked at it in 26 healthy volunteers. They looked at this drug, though, with weekly subcutaneous injections and found that at day 22, there were 80% mean reduction in TTR. So very potent ways of reducing TTR overall. Now, both of these technologies have been tested in phase 3 trials. However, none of these data have been published. They've all been distributed by company presentations at TTR meetings. So I thought the best way to look at this data was to just compare some of the prominent findings. So the two main companies who are fighting to push their drug out into the market for this particular need are Alnylam and Ionis. Alnylam uses the siRNA technology, and their drug that just completed a phase 3 study is called patisiran. This was used in the Apollo study and presented in November at this European meeting. This drug is given by IV infusion and requires a pre-medication with steroids, dexamethasone, to prevent IV infusion reactions, so that's something we have to keep in mind. And the study population was not a cardiomyopathy patient population. It was a polyneuropathy patient population that then they did subgroup analysis and found that 50% of them had concomitant cardiomyopathy. And in this subgroup analysis, they found stability of overall cardiomyopathy over a span of 18 months. So subgroup analysis. Same thing with Ionis. Their drug is inotersen. It's an antisense oligonucleotide. They looked at it in this neuro-TTR study, and this was given via weekly subcutaneous injections. Again, the patient population was not a cardiomyopathy population, it was a neuropathy population, but then did subgroup analysis in the 60% of patients who also had cardiomyopathy and found stability in their cardiomyopathy. I think it's important to mention that revusiran was also a drug made by Alnylam, which was studied in the Endeavor study, which Grady was a enrolling site, and we sent some of our patients to be enrolled in this study, that had weekly sub-Q injections. However, this study was halted due to safety concerns because of an imbalance in mortality. There are 16 deaths in the study arm versus 2 deaths in the placebo arm. And after multiple reviews, they cannot conclusively say that the drug led to the deaths, but nonetheless, the drug was taken off research platforms, and the company itself has abandoned the conjugate method of of delivery of this siRNA. So these technologies are really exciting and are potent, but the only study in TTR cardiomyopathy patients using this technology was the Endeavor study, which was halted because of an imbalance in mortality. Finally, fibril degraders, there's not, again, much data to support their use, but it was found that doxycycline could disrupt amyloid fibrils in a mouse model. However, the data that we have in patients is from open label studies and not much to really hang your hat on. Lastly, there's a monoclonal antibody towards TTR that promotes clearance of the protein, and this is going to start phase 1 study soon. I'm going to go really quickly through AL amyloid because this is, again, more a treatment that's given by our hematology oncology colleagues, but nonetheless, the therapy is to stop plasma cells because the plasma cells are the ones churning out this abnormal protein. The one new thing in this disease has been proteasome inhibitors. So the proteasome inhibitors have really changed the disease trajectory significantly. Now, the first-line therapy is cyclophosphamide, bortezomib, which is Velcade, which is the proteasome inhibitor, and dexamethasone. And as you can see here, with the use of this new therapy, the estimated 4-year survival has gone up to 50%. And Rob and I and some of our heart failure colleagues have patients who, in the past, the thought was if you had AL amyloid with cardiac involvement, your lifespan was 6 months, 50% survival at 6 months. Now, with the advent of these new therapies, you can see that 4-year survival is up as good as 50%. And we have patients who are now 6 to 8 years out from their initial diagnosis and treatment of AL cardiomyopathy. Novel therapies, there are a lot of novel therapies also in AL amyloid. Primarily are targeted with antibodies to this abnormal protein, but they're in early development phases. So to summarize again, TTR cardiomyopathy is prevalent in our patient population and likely underdiagnosed. Technetium pyrophosphate scanning is highly sensitive and specific and should be a good tool for us to use and can pretty much eliminate the need for endocardial biopsy in up to 75% of our patients. There are multiple therapeutics on the verge of approval, as I've shown you, and we think that there's a large unmet need in the community. And for this reason, we're developing a new comprehensive multidisciplinary clinic. We're hoping we have already collaborated, but overall, the multidisciplinary clinic will have Dr. Kaufman and his partner in hematology, myself and Rob Cole in the heart failure transplant group, and there are clinicians both in neurology, GI, and nephrology that are interested in being part of this clinic. And this clinic, we hope, will give access to not only novel therapies, but also access to clinical trials that are upcoming, as you've seen. Thank you to Dr. Cole and Dr. Smith, who have sparked my interest in this field, Dr. Laskar for his support, and Apesh, who's been helping with some of our retrospective review data. Thank you.
That was great. I'm going to start off with 2 questions. I'll give you 2 this time. So one is, with the TTR that has a single mutation etiology, or is there thoughts about CRISPR for definitive repair? And then the second question is, why does the technetium pyrophosphate work? Yeah.
I'll start with the technetium pyrophosphate one. So they're not 100% sure why. They think that it's because the amyloid deposits have a lot more calcium in them, and more so in the TTR amyloid plaques have more microcalcifications and then are avid to bone tracers as opposed to AL. But overall, it's thought to be more discrepancy of calcium composition in the plaques, but not clearly known. CRISPR itself, through my data review, did not see much of CRISPR being used in this, but I'm sure it will eventually.
Questions?
I think for those of us who don't know, can you describe what CRISPR is?
Yeah, it's a gene modification method.
Yeah, CRISPR is a way to new gene technology. It's been CRISPR-Cas9 is an endogenous way that repair happens, but it comes out of bacteriology or literature, but it's a way to basically replace genes in a very specific way. And so instead of doing gene therapy and sort of hoping things stick and getting off target effects by disrupting, you can go in and precisely splice out that variant. And clinical trials are underway, for example, in sickle cell, where you have a single point mutation. And that's thought to be one of the more attractive targets for CRISPR, and that's why I was wondering about it with that. Okay, so that's my, there's a lot more to CRISPR than that, but that's the short version. Any other questions?
Yeah.
So I can think of several patients in my clinic who have, diastolic dysfunction and maybe a peripheral neuropathy. So it sounds like a lot of these treatments could be available in the near future. And I was wondering what you anticipate would be the recommendations for who should be screened.
So I think there are some clear red flags. So if you have an elderly patient with diastolic dysfunction and unexplained LVH, that's a patient that you should definitely be thinking about screening for TTR wild type. If you have a patient who's, between the ages of 60 and 70, who's African American, who tells you they've had bilateral carpal tunnel surgery, has spinal stenosis, has a history of hypertension, but his LV wall thickness is 1.9 centimeters, seems disproportionate to the amount of hypertension that he's had, that's a patient, especially in our patient demographic that we see at Emory, that we should be screening for TTR amyloid. And then in terms of therapeutics, this Tafamidis, which is the TTR stabilizer, holds the best promise in the next few months. The data should be presented at the ESC meeting in August, and the data has already, I think, been sent to the FDA. So hopefully by the end of this year, we'll have Tafamidis available as a TTR stabilizer. And I think with the advent of this pyrophosphate scan, which is easy to screen patients with, and the fact that we're going to have therapies to offer our patients, there's going to be a huge impetus to diagnosing these patients. Yeah, good question. So I've been working for the last 2.5 months, both with Dr. Vadney and Dr. Patterson at Midtown, and our nuclear radiologist here, Dr. Halkar and Dr. Moncayo, to get the pyrophosphate scanning into our Emory system. It is pretty much ready here on the Clifton campus. We have a meeting tomorrow with them to solidify the reporting system, how we're going to order it in EMER. And once all of that is, I'm hoping in the next 3 weeks, we'll have all of that solidified. And then I can either send an email to our group, or there'll be other forms of distributing how to order this test.
Thanks. This may not be available, I guess, but you mentioned that Tafamidis was approved and used in other countries. Is there a sense of the likely magnitude of the effect of the drug? I know it was approved for neuropathy in other countries, but is there a good sense of what it's doing from a cardiac perspective in terms of magnitude?
We've not seen a publication like the one Dr. Moore published with his experience over the last 5 years in a TTR cardiomyopathy cohort. I'm sure that data exists in Europe, and it just is a matter of people, publishing it. I bet that the UK group that sees over 1,000 amyloid patients a year probably has the best, but has not been published yet.
Kunal, that was a fantastic presentation, and I definitely learned a lot. It was brand new for me. To me, it sounds like the floodgates could really open up here with essentially the explosion of HFpEF patients we have. And I was going to follow up on the question that Rebecca asked, because I can think of dozens and even more patients in my clinic that I've probably been missing this on over the years. And so, in terms of screening, you said the EKG is not so helpful. We have so many patients, elderly patients with diastolic dysfunction, who may have a normal EKG or have LVH or left bundle, so that's just a massive cohort. And then the echo, obviously if you see the thickening of the valves or the classic amyloid picture, that's one thing, but I wonder what the sensitivity is, and then who gets referred to you guys, how much of that workup do we start ourselves? I think it's very exciting, but just further guidance on that front.
Yeah, I think once this drug is available by the end of the year, I think it's going to be very important for all of us to think about in these patients screening for TTR amyloid. Probably if your echo seems suggestive and your EKG, the concept is not just low voltage on EKG, but a disproportionate amount of voltage to LVH. And there have been studies that look at these formulas that calculate total voltage divided by LV mass. I mean, they're a little convoluted, but the basic point is LV mass on echo versus voltage having some disproportionality to it. In those patients, with the pyrophosphate scan, which will hopefully be easy, quick, not expensive, this tracer's been around since the 70s, should be the way we go about screening for patients. Of course, in patients who want additional therapy, who want to be put on another drug on top of already their cocktail of medicines. And it's important to say that, like you said, there's going to be an explosion of wild-type TTR patients that we diagnose, for sure. Dr. Gilmore at the UK Amyloid Center showed data recently at the meeting in Japan where there was an inflection point after they introduced pyrophosphate scanning in their center, where the diagnosis made for TTR and mutated wild-type TTR sort of exploded exponentially over the last 3 years or so since the advent of this technology. So I think the pyrophosphate scanning will be important. But the wild-type TTR, probably is purely the reason for somebody's cardiomyopathy in 5 to 10%, okay? Probably it's going to be just another contributor to the presentation of HFpEF. A little bit of wild-type TTR plus hypertension plus OSA. It's not so much that the wild-type TTR will explain all of our HFpEF patients who have LVH, but it'll be a component of that disease presentation that now we'll have a therapy for. So you'll treat your hypertension, you'll treat the OSA, and you'll treat further wild-type deposition with the new drugs that are coming out.
Dr. Bhatt, excellent presentation. So my question is 5 to 10 years from now, I wonder how much the Tafamidis really will impact the patients who have severe LVH and have symptomatic heart failure. Do you see a role where patients are getting screened, families are getting screened, and then those families, before they develop clinical disease, are being treated with some of the newer agents?
Yeah, I think that's where the field is headed. I think if you're diagnosing patients who are New York Heart 4, who are 70 plus, putting them on tafamidis is not going to change their disease trajectory. However, screening, and I took out a case for the purposes of time, but there was a patient that we saw here who's 76 years old, had been seen by multiple other hospitals, been sent to us for failure to thrive. He actually had end-stage cardiac amyloid. But the importance in diagnosing that disease for him was more so because his progeny, his 4 children who were between the ages of 50 and 60, were then screened for TTR amyloid. And in those patients, we can really change the trajectory of disease by these therapies. So really, right now, the elderly patients we have, the reason for doing genetic testing on them is because they may have wild type, but they also may have mutated TTR. And in those patients, we can really help their children with these new therapies. And I think the other direction that's headed is, we're going to have multiple different therapies in the next year to 2 years. There'll be, siRNA technology plus the stabilizers, and in patients who have advanced cardiomyopathy, maybe you use both combined. In patients who are early onset or still preclinical phases, you maybe just put them on the stabilizer itself and not expose them to IV infusions and things like that. So I think a lot more to come in this field.
One more.
So I guess when you're talking about the echoes, rather than saying LVH, we actually ought to talk about the thickness of the wall. So that is, if we have a thick walled left ventricle, then if there's a dichotomy between the wall thickness and the EKG, then you can think of an infiltrative cardiomyopathy in which all the cells are insulated electrically from everything else. So what we often see with that is I find myself looking at the EKG in the patients who are on dialysis, for example. And you go look, and there's a EKG that shows LVH So then you kind of put that aside and say, well, I guess this is a patient on dialysis that has LVH. How do you explain what looks like in the precordial leads a lot of voltage in LVH versus what looks like in the standard leads low voltage, as you showed in your tracing, as I've seen so many times?
You know, the exact reason why these patients have low voltage is also not completely understood. And I say that because they know that AL amyloid patients who have infiltrated cardiomyopathy, AL amyloid, the light chains are very cardiotoxic. So it doesn't take a lot of that protein to be deposited in the heart to cause profound cardiomyopathy. So there's a little bit of AL amyloid deposition in the heart, but it causes a profound cardiomyopathy, and their EKGs look more like low voltage than the TTR amyloid patient that I showed you with a wall thickness of 2.7 centimeters. So there is a discrepancy, and they think it's more to do with the myocardial dysfunction than it is insulation of this amyloid protein.
Do you think, Kunal, that a normal EKG excludes any kind of amyloid of the heart?
No, I think what the data shows is, yes, for low voltage is more common in AL amyloid, but low voltage is not very common in TTR amyloid. And TTR amyloid is the more common disease that we see in clinic. So a normal EKG, to me, is just a piece of the puzzle. It's more so putting all of these different pieces together.
So I would think a normal EKG would be a good marker of amyloid not likely being present, but just my thought.
Yeah.
All right, fantastic. That was really, really good. Thanks.
The preceding program is copyrighted by Emory University.